fast. Okay, so I'm going to talk about pediatric trauma. I'm not going to teach anyone here how to manage pediatric trauma, but I'm going to remind you with a few things that makes a difference for the children. So again, I have nothing to disclose in here. And then let's go for the tips of tackling pediatric trauma. Now, calming and distractions. A trauma resuscitation can be quite very overwhelming for an adult. How about a child? Honestly, even when we go to the hospital, we daily go to the hospital and that's our work. But did you notice when you go as a patient or you go that you're seeking medical advice, you start to smell the smell of the hospital, that we are living in it 24/7. You start to get the abdominal pain that says, I'm in the hospital. And this is, we're adults, but we're quiet about it. How about children? And that's true. So we need an age-appropriate interventions with the children. That child is lying helplessly on a backboard, strapped there. Everyone is looking, everyone is touching, but no one is speaking to that child or calming that child. So involve the caregivers. Utilize mom and dad. Well, I'm not going to say utilize grandparents because that's going to be a hell of a hard time, but utilize the people around. So sometimes we push parents because we want to help their kids, but again, they will be a very good helper. Because when you calm mom and dad, that child will be calm, because this is the key for them. Then, pain control and anxiolytics. Remember, we do everything. We try to give them the pain management. But I think we're a little bit behind. We need to be ahead of our time when we start the pain management. We do all our ABCs and everything, then we give them the medications. So remember that very well. And then check the bedside sugar. And I always say A, B, C, D, E. Now I'm gonna add for you D, E, F, G. Do not forget the glucose, please, because they can go hypoglycemic very fast. So to manage a pediatric trauma, you really have to be very handy. How can I be handy? Let's do a few stuff. So, number one, have always a table of the vitals up to appropriate age, roughly. We remember them by heart time because we've been practicing for long, but for beginners or for people still, you can have it very handy, and we have everything on the tip of our phone now, right? Remember the PALS guidelines for the blood pressure, and that is the rock science, right? So you need to know the blood pressure because that will make your management steps way different. And then Broslow tape is an amazing tape. We know it, we see it, but how many of you really utilize it? I want to see hands. How many utilizes the Broslow tape when a patient comes to a trauma bay or a resus? Only those hands? It's there, it's beautiful, it's colored. You know what, I would suggest in your off time, or when you're having a cup of coffee, see, we always utilize the time. Look at the Broslow tape and read it very well. Look at the top and the back and the front. It's amazing, handy one, and it helps a lot. Now, children have different anatomy and physiology than us as an adults. They are higher metabolic rate, and they have a smaller functional residual capacity. So they last long with their SATs, but when they boom down, they go down 90 degrees and they desat very fast. Then the compliance of the chest wall. They really have a poor protection to the underlying structure. So they will absorb all this trauma. Their flexible thoracic cage would be allowing that energy to go to the lungs. They're not gonna fracture the ribs, but they're gonna have a very bad lung contusion, which is not gonna appear now, but is gonna appear after some time. Thin abdominal wall musculature, that makes the protection for the organs is very minimal. The liver, the spleen, are a little bit out of the area there. Nothing is protecting, so they are very liable to get the abdominal organs injury. They have very flexible tissues. It can be an advantage. That's why they have a low risk of aortic traumatic injury, but their airway is very easy compressible because of that flexibility. They have relatively large head and occiput, and that will make the hyperflexion for the children with a neck trauma is more of a risk for them. Now, underappreciating hemodynamic instability. Shock can be very challenging to be recognized in children. Now, children compensate very well. Two things in children, and that's what I learned over all these years. two things, they last very well in the good numbers, and they give you reassurance in the monitor, blood pressure and saturation. But when they go down without mercy. And you should be on top of that before they go down. That's the reality. So don't look at the blood pressure, look at the cap refill. The cap refill will be affected, but the blood pressure is still hanging on. When the blood pressure down, you're late. So that's the way we learn the lesson. IV line, utilize an intraosseous. Don't try to figure out a big vein in a small child while they are in trauma. If there is a blood loss, think of damage control, resuscitation rather than anything else. So minimize the bleeding as much as possible. Now, overutilization of CT scan. How many of you did a pan CT scan on a trauma patient? Okay, pan CT. Okay. Nowadays, pan CT is almost not recommended in children, provided, be careful with my statement, that you are having system targeted CT scan. So no one CTs from head to toe unless things are out of ordinary. In my 25 years of practice, I did it only once, and it was worth because he needed the pan CT. But after that, you just target the things. So weigh risk and benefit. Ionized irradiation is really a risk. There is a recent study last week that said it is real because people thought, oh, this is myth. It is real and it's a big thing. Scanning should be done. Do not order a pan CT, as I said, unless you have justification for it. Low mechanism head of energy of injury, go for PCARN, go for the catch study, go for the rules. Then the rules will guide you. I'm not saying for a severe head injury, severe mandates a CT and we're done with this. Chest CT, you'll be surprised that is not the big yield. All the studies have been proven until this moment, if the chest X-ray is normal and if the patient is doing well, there is no rule for a chest CT in a child. Plus, it's the highest radiation exposure all over the body. If you want to exclude any CT in any child, I would exclude the chest because the radiation is too high in that area. And don't forget about the serial blood exams, abdominal exams. Fast is not the best, but again, it's sort of aiding to your help. Now, underappreciation of potential of non-accidental injuries. For an era, I think we slipped over that and we did not put it a lot in our mind, although we have been trained to come and look for it. Look for it very well. That could be the real presentation of a non-accidental injury as a trauma patient, majority of them. Head injury is the most common and the most lethal non-accidental injury. In fact, most of the children I lost because of this, they were head traumas. Now, any suspicion? Follow your hospital policy, and if you don't, follow the national of the kingdom policy, right? And these cases have to be reported. Now, effect of toys made from medical material on an anxiety of the hospitalized children. Let's get a quick now. They did a beautiful study, and they came to the children who were hospitalized, and they did an anxiety scale. And they looked at that. So they put the children who are going to go with the usual standard things like inpatients, everything is fine. And then they went to another thing and they said, okay, let's make toys out of the medical instruments. So they made the rabbit with the gloves. They made with the tongue depressor the cat. They made the aircraft from the IV cannula, and guess what? The children helped them in doing it. What are you expecting with this? When they checked the anxiety acuity scale, it was way different between the randomized and the other group than this. Plus, when they did that also scale with the parents, everyone was so happy with this. It's so simple. So when you look at it, I personally think I will adapt this, and I adopted. The instruments are there, everything can be done, but for the children anxiety, it makes a big difference. So when they did this, this is what they found. Everything goes different from a simple cannula that scares the child to converting it to an aircraft, from the gloves that scare them, making them into a rabbit, and the tongue depressor that everyone gags when they see we made out of it a cat. So just an idea to see. Now, when we go to the pediatric airway, 3 P's, and remember this very well, right? Patency. use of the good preventive measures of the obstruction. If you look at the babies, they have a big head, children generally, big occiput. So when you put them neutral, in fact, they are blocking their airway. So you need to put something, usually they put it under the head in adults or big people. We put it under the shoulders to overcome their big occiput. So you need to make sure that simply their respiratory problem is only mechanical and can be sorted out. Position, towel under the torso as we said, and then protection. Cuffed tubes are the recommended endotracheal tubes for any pediatric patients, including neonates. So find the proper one, which is age divided by 4, the famous formula we know, +4, make it +3.4. And if you're getting +4, remember this, you just minus 0.5 out of this. Now, for head injury, brain injury is the leading cause of the pediatric death in the polytrauma. The goal of this, I'm not gonna change what injury happened, and I'm not gonna change anything happened there. What I'm gonna do is prevent getting it worse, which is the secondary brain damage. So when you look at them, look at the 5 compartments that you think. Hypotension. Hypotension is gonna make their problem with the with the brain perfusion. Hypoxia. So never allow them to go below 90. 92 is your target always. Hypothermia, warm crystalloids, warm blood. Remember, we take these patients, we put them in that cold emergency room, we take off their clothes by the scissor, and we leave them exposed for some time. So bad hypothermia is not needed, but we need the usual euthermia, which is needed there. Hypoglycemia, again, remember that, glucose. If you have 4 vitals, that's the 5th. If you have 5 vitals, that's the 6th. And then the raised ICP, so make sure that you put them in a 30 degrees, remove the collar, pain and anxiety relief, because they have to be calm and comfortable. If you got a minor head injury or moderate, now you have the PCARN and you have the other rules. MDCal is a very beautiful app that I have nothing to do with it, but once you enter everything, they will calculate and they will give you the recommended PCARN rules for it. Pearls and pitfalls for the RSI. The pearls would be, use a straight blade when you intubate the patients. And that's the best way to give you a good visualized airway. Have a weight-based drone in advance, and that's way better. Pre-induction, consider atropine for the young children, because atropine is a bit of a funny story. It was must, then everyone banned on it, and they said, you can use it. The advice would be anyone below 1 year, they are liable once you put that blade and intubate them to go bradycardic. And when they go bradycardic, they don't really come out very easy. So if your baby is young, and I personally in the first 3 months, if I intubate a baby, I pre-medicate them with the atropine, preventing that brady episode that will happen. And then observational study from 1,412 emergency pediatric intubation, they found the video-assisted intubation has a higher success rate if it's in the first trial than anything else. I'm saying this, but I'm still a classic lady who goes directly with the simple straight scope. But again, utilize your new things. Now, the pitfalls, inadequate pre-oxygenation time, these guys are going to doom down very bad and will interrupt your intubation. Consider early NG placement to deflate the stomach, because probably you've been bagging that patient or he was crying for a while. And then right main stem endotracheal intubation per se. Once you push your tube, you know very well that you're in, then we listen, make it a rule, size of the tube multiplied by 3. This is where the ET tube at the left side would be. And then cricoid pressure is not recommended anymore. What's recommended is external laryngeal manipulation. If you've done a lot of pediatric intubation, sometimes what we do, we don't do the cricoid pressure. We push and manipulate the larynx so the person who's intubating can see very well. Then overbacking, be very careful. Use a pop-off. Your emotions, your epinephrine, there's a child who's dying in your hand, so you are bagging, but you're not realizing how much pressure you're giving to that tiny lungs. So you either use a back valve pressure gauge, or look at the chest rise and don't hyperinflate the chest. When it comes to the C-spine, now, The incidence of the pediatric spine injury is overall, to be honest, less than 2%, which is a blessing, thank God, and the majority is at the level of C1 to C3. Now, since the vast majority of the C-spines are going to be in sort of a head injury patient, so if you are scanning the head, you will take the first few cuts until C3. Don't go extensive on anything, because this is where majority of the injury, unless you have a real grounds of saying, I have a C-spine injury. So most of the time, if you did a brain CT, you already have seen C1, C2, C3 in the cuts. So utilize it. Don't look at the brain and leave the spine. Utilize the amounts of information you have. Clearing the pediatric C-spine is a little bit complicated. Usually they are not going to be reliable. They're screaming, they are crying, but try to have a reasonable thinking and get out the distraction of the way. Atlantoaxial injuries are more common in children, and that's the problem. Yes, we're happy that only C1, C3, but they have a lot of atlantoaxial injuries, liability. Horizontally oriented vertebral facets and physiological wedging at the vertebral bodies can make them dislocate very fast and easy. When we go for the chest, deflating the stomach can help the patient a lot to breathe, so don't always think that the problem is only the lungs, a problem that you have an overextended gastric bubble of air. So try to relieve this. POCUS is highly sensitive in a pneumothorax. Yeah, we are not so happy with the fast in the abdomen, but the pneumothorax can be picked up in adult and pediatric nicely with the ultrasound. Pigtail catheters nowadays, you can insert it for the pneumothorax, and it's fair enough, we don't need to go for the big major chest tubes. The pitfalls is, don't expect traditional adult injuries in these children. They will have initially a normal chest x-ray. Be vigilant and look at them. Within a few hours, you might find yourself repeating the x-ray, and now you can see the lung contusion. But the pneumothorax is going to appear regardless. You might miss the early finding. That's why you have the follow-up for these patients. For the abdominal injuries, vast majority of pediatric patients with abdominal trauma are treated conservatively. Only 5% require surgery out of your all injuries. And that's a good sign. Even if we have an injury, it's very conservative management. The spleen and the liver are the most commonly injured organs in the blunt trauma, and that should raise the concern for the pancreatic or duodenal injury. We said they have weak abdominal muscle, thin walls, so they are liable for it. Any polytrauma patient, hemodynamic instability. If you have a hemodynamic unstable patient, think abdominal bleeding, lung, or let's say thoracic bleeding. And if they are very young, that would be a bad head injury with a bad bleeding, because their skull can accommodate. Abdominal physical exam is misleading in 20 to 30% of the patients. That's why you keep doing serials of abdominal exams. Be aware of the mechanism. If you have a seat belt, think of duodenal hematoma or something major. If you have the other signs, that can guide you and help you. Serial exams is the key. Now, does the combination of cartoon stickers and fruit juice reduce the pre-medication and anxiety? And I love this study. So they came to the patients who are going to go for the OR. And why I'm saying this, because no one have done it in ER, and probably that's maybe a suggestion, let's do something like this. This is where we can play a lot of games with these kids. So what they did, they brought 4 arms in the study. Traditional usual one, that they'll come, they give them their pre-medication, they'll take them to OR. Then the second group, we're gonna get the pre-medication with the cartoon sticker. Then the third one is going to get the pre-medication with the fruit juice. And then the fourth one is going to get the sticker and the fruit juice. Who you think have won? Stickers. I mean, I'm an adult. If you give me a sticker when I go to ER, I'll be very happy. Seriously. Who resists stickers, right? So, stickers plus fruit juice. Those kids were wow. They did not have that anxiety. They were fine. They went to the OR happy, waving bye-bye, and everyone is happy. And it's simple sticker. So we have a lovely fellows, And in fact, they got us the base of that sticker rollers that the kids, when they go to the ER, the first thing, and it sounds like a rumor going on, do you have a sticker? He says, yeah, go and choose which roll you want, and they pick it up, and they happily go in there, and then we promise them another sticker when they get the needle, so things would be fine. My point is, let's take care of these kids. Trauma is going to be managed, but the only thing is the child managed the way that he deserves to be managed, right? So, the things that you need to know about the pediatric trauma. Pediatric patients are very stressful. They are not only the patients, it's mom and dad, it's grandparents, it's the whole tribe in that room. Everyone is screaming and yelling, and the kid is looking at his mom crying, dad is crying. Do you think they will be calm? No, they will not be calm. That's true. The second thing is manage the family, and the only way you could do the family is engage them, but engage the people that can listen to you, can be on the same track with you, and I usually visualize the weakest person that I just put them aside and get the people who can really distract that child with me. Airway management is not the same as intubation. So when you have an airway problem, intubation is the last thing you're gonna do, and that's the step that you will think of, but think of positional, adjusting airway, doing adjuncts, because mainly and mostly this is the reason for this. Perfusion is much more important than blood pressure, and remember the cat refill can help you a lot. For hemorrhage, think damage control, then fluid resuscitation. So start with a bolus of fluid, control that bleeding. Second bolus is going to be definitely a blood, as long as I know that there is hemorrhage going on. Little kids have big heads, and remember, these are dilemmas when you put them there. Injury present differently in children. They don't have the same pathophysiology nor the anatomy of our body as adults. Be alert for non-accidental injury. It's really major. Unfortunately, in the last few years, we have seen a lot of cases that is really causing a lot of distress for most of us. Don't forget about pain, please. Pain. Kids would love you once you give them pain management, once you promise that. And you don't have to go for needles, and you don't have to go for this. What you could do is, you can use an intranasal midazolam, you can use something simple in these kids. They would love you, they would be very happy. Then you initiate your IV line. Pediatric patients do better in a pediatric hospital, and that's a study was done. If you really elect to do anything, I would love to resuscitate a patient in a pediatric hospital, and hopefully this is most of our kids would be happy. Thank you so much.